Okay, good afternoon. Thanks to the organizers, and the slides have been provided by Novartis. We will be talking about CERETINIB, frontier in the line management of first-line advanced ALK-positive NSCLC. This is a disclaimer. So as we all know, the NSCLC is heterogeneous and we are getting more and more mutations which are positive in NSCLC. So, and ALK positivity, the range is 7 to 8%. I think in the TMH data also it is around 7 to 8% in NSCLC, and it is one of the important mutations. Now, molecular technology preference testing basically varies, and for ALK positivity, we have essentially three methods. You have the IHC. For example, the Crown study used IHC, immunohistochemistry, as the test to determine ALK positive status. You have the FISH, which was the classical break apart FISH, and you have the NGS panel, which not only tests for ALK but also others. Essentially, we require DNA and RNA based testing in NGS to determine fusions, and multiple genetic tests required large tissue volumes and sequential testing for EGFR, ALK, ROS, and if it negative, then further testing is almost nowadays never done because we have moved to NGS as the test of choice. ESMO as well as NCCN recommend NGS testing, and what are the benefits of NGS testing is you have a reliable detection of standard of care mutations with good sensitivity, specificity, accurate identification of up to 3 times more clinically actionable alterations. NGS testing panels may provide data for all known mutations. So you have co-mutations like P53 which actually impact the outcome in EGFR as well as ALK positive NSCLCs. And nowadays the turnaround time is also acceptable. So overall NGS is the way to go. Also what is more important nowadays is that you have cost effective NGS. So you have these 12 or 15 gene panels, which please note that they also contain other co-mutations like TP53, which has been shown to have a negative outcome in EGFR as well as ALK positive patients. And this Novartis does support testing, and also PD-L1 testing is combined with NGS in sort of this service provided by Novartis. Now we come to CERETINIB. First line CERETINIB versus chemotherapy in patients with ALK positive lung cancer. ASCENT-4 was the study. It is some time back, so it is comparing ALK positive metastatic NSCLC in the first line setting, no prior treatment, stratified by performance status, brain mets, and prior neoadjuvant adjuvant therapy, randomized in a 1:1 fashion. Please note the dose of CERETINIB. It was 750 milligram once a day versus PEM platinum based chemotherapy. So either PEM-CIS or PEM carbo, and patients who received chemotherapy also received pemetrexed maintenance. And there was an option to cross over later on. 80 patients cross over to CERETINIB. So CERETINIB doubled the median PFS as compared to chemotherapy. So the median PFS was 16.6 months versus 8.1 months, hazard ratio of 0.55, thus a 45% risk reduction of death or progression as with compared to chemotherapy. Overall response rate was impressive, 72.5%, duration of response around 2 years, and 24-month overall survival rate 70.6%. In the Asian subset also, CERETINIB did have an impact. The separation of the curve is slightly later, but again the median PFS is 26.3 months versus 10.6 months. Hazard ratio 0.66, 34% reduction in progression or death, even though the confidence interval is slightly crossing 1. What is interesting is this with Novartis is that this study was conducted, because usually we sort of, once the dose is established 750 milligram, you don't tweak around with the dose, and especially you don't reduce the dose. But in this ASCENT-8 study, you actually had 3 types of dosing. So one was CERETINIB 450 milligram with meal, CERETINIB 600 milligram with meal, and CERETINIB 750 milligram fasting, which was the dose used in ASCENT-4 study. And the primary endpoint in this study was not clinical. It was a steady PK of CERETINIB in all these with all these doses, and no clinically meaningful difference was seen in the pharmacokinetics studies with all these 3 doses. But what is important is if we look at the secondary clinical endpoints, the dark red is the 450 milligram fed state dose, the orange is the 600 milligram fed, and the dotted blue line is the standard dose which was used in ASCENT-4, which is the 750 milligram in fasted. you actually are seeing, as far as the duration of response, the PFS and the OS, the 450 milligram with meal dose is doing better. And if you look at the overall response rate, it is around 80% for all these three. But if you look at duration of response, 68 versus 44 versus 20. If you look at PFS rate at 24 months, 58 versus 37 versus 22. So definitely 450 milligram PET state dose probably was the way to go, and that is the standard dose. So 150 milligram pill, three pills taken with meal is the standard dose which has been approved. So it saves on cost, and also this dose has lesser side effects. So lesser GI side effects as opposed to the 750 milligram fasting dose. Now, brain mets are an important issue with ALK-positive NSCLC, and you have 30% of patients might have brain mets at baseline, 70% will not have. So patients who have brain mets, you require a TKI which penetrates the blood-brain barrier, and CERETINIB does penetrate the blood-brain barrier and has a good intracranial efficacy. In patients who do not have a brain met at baseline, prevention of progression in the CNS is also very important. And again, CERETINIB being effective in the CNS has that impact also. So if we look at the site of metastasis in ALK inhibitor naive patients, if we use the first generation crizotinib, CNS was the primary site of relapse in almost half the patients, 46% of patients. And next generation ALK inhibitors with increased blood-brain penetration may have high volume in the first line setting. Not only to control the CNS mets in patients, 30% of patients who have brain mets at baseline, but to prevent the development of brain mets in the 70% who do not have brain mets. So again, in patients who had brain mets, the PFS was 10.7 months versus 6.7 months. In patients who did not have brain mets, the PFS was 26.3 months, that is more than 2 years as opposed to 8.3 months, thus reflecting the intracranial efficacy of CERETINIB. If we look at the intracranial response rate, so if you look at the overall intracranial response rate, 72.7% versus 27%, so a 45% delta, and you have a reasonable duration of intracranial response, 16 months. And again, if you look at the best overall intracranial response rate with CERETINIB, there is a high intracranial response rate, 44% versus 22%. Systemic whole body efficacy is 65 versus 29, but intracranial response rate is also significantly better with CERETINIB. Now, if we look at the comparative efficacy of CERETINIB and crizotinib, so there is no direct comparison. CERETINIB has been compared with chemotherapy, crizotinib also has been compared with chemotherapy. Lorlatinib and alectinib have been compared with crizotinib, but if we look at the PFS, so 10.9 months with crizotinib versus 7 months with chemotherapy. If we look at ASCENT-4, 16.6 months versus 8 months. Overall survival data, because of crossover, we cannot comment, but there is a reasonable overall survival data for both of them. If we look at the safety profile, CERETINIB acts fast also. There is a good response rate, and you see that the time to definitive deterioration is also significantly prolonged with CERETINIB, 23.6 months versus 12.6 months, and there is an early separation of curve, thus reflecting that not only is there is a good response, but there is an early response. Also on the right, you are seeing that there is a treatment difference in lung cancer specific scores like dyspnea, pain, and other parameters in symptoms related to lung cancer, and CERETINIB thus significantly improved the quality of life and significantly prolonged the time to deterioration of lung cancer specific symptoms as opposed to chemotherapy. Now, what are the side effects of CERETINIB? So CERETINIB main side effects which we should be aware of is diarrhea, nausea, vomiting, abdominal pain, and hepatotoxicity. If you look at the label, there are other side effects like pancreatitis. CERETINIB does cause QT prolongation, and I think baseline ECG is something which is warranted. So here, what you are seeing with CERETINIB is 5% to 5% diarrhea, grade 3, grade 4, vomiting, grade 3, grade 4, and hepatotoxicity, you are seeing around 20 to 30% grade 3, grade 4. So this is what is important, but with proper management, so with proper counseling the patient, giving prophylactic antiemetics probably for the first 1 to 2 months of treatment, and using the proper dose, that is 450 milligram in a fed state, these GI side effects are manageable. You have a lot of options for ALK-positive NSCLC. You have lorlatinib, crizotinib, CERETINIB, alectinib, brigatinib now, and how do we choose them is a question. And the first drug to be effective was crizotinib, followed by that CERETINIB, alectinib, brigatinib came, and nowadays there is a lot of discussion on the Crown study data. Lorlatinib is one of the drugs which we consider, especially because of the increased intracranial penetration. So what are the options? So if you look at the NCCN guidelines, you have all these options in the first line. If at all chemotherapy is started, there is an option of completing that and switching over to ALK inhibitor. But what is practically possible in India? Practically, CERETINIB remains the most cost-effective treatment for ALK-positive patients in India. The cost of monthly treatment is around 45,000. And practically speaking, this is one drug which has intracranial penetration. It is cost-effective, and the GI side effects, etc., are manageable. Overall, this is probably the most feasible to be given in India as of now, and thus maybe most of the patients might receive CERETINIB as opposed to alectinib or lorlatinib if we talk about cost. Also, if we look at the sequencing, there is data that CERETINIB followed by alectinib or lorlatinib may have a comparable efficacy, but now the updated Crown study shows 60% PFS at 5 years, so 60% at 60 months. That is impressive, but again, there are two issues. One is that how many patients will actually afford lorlatinib. Second issue is lorlatinib is associated with some CNS related side effects, etc. And also we need to sort of become better at managing them. Obviously, if the patient can afford, lorlatinib is a good drug as of now, but CERETINIB is probably the most affordable, feasible drug in Indian setting. Now, points to consider while using an ALK TKI: superior efficacy in the first line. So basically, you want a drug which will penetrate the blood-brain barrier, have intracranial penetration, because many patients may not receive a second line. If there are no brain mets at baseline, we need to use a drug which prevent the brain metastasis, and CERETINIB sort of fulfills that requirement. If there are brain mets at baseline, 30% of patients, we require a drug which will cross the blood-brain barrier and have a good intracranial response. That again, CERETINIB will fulfill. Symptomatic disease, again, you saw the quality of life curve, you saw the response rate of around about 70%, and you saw the rapidity of response. So again, CERETINIB fulfills that requirement also. And do we have a second line post-CERETINIB? Yes, we can use drugs like lorlatinib post-CERETINIB also. And if we are using the front line lorlatinib, we probably don't have clear-cut evidence that what is the second line we can use. So again, CERETINIB fulfills most of these requirements in treating ALK-positive advanced NSCLC. And to conclude, in ASCENT-4 study, ALK inhibitor naive patients, first line setting CERETINIB versus chemotherapy, CERETINIB showed significantly improved PFS, numerically improved OS. PFS benefit was also seen regardless of the presence of brain metastasis. Gastrointestinal adverse events were prominent: nausea, vomiting, diarrhea, and hepatotoxicity, but were manageable. And 450 milligram dose was then sort of the dose to finally sort of settle the issue that 750 milligram fasting is inferior to 450 milligram with meal, so that is the dose we give. And efficacy and safety of CERETINIB was also established in Asian patient population with ALK-positive NSCLC. I have come to the end of my talk. Thank you.